how to interpret, read our stroboscopy, and the various drawbacks. We have often come across these kind of images. This is nothing but strobe effect. Stroboscope was invented by Simon Ritter von Stamfer and who also coined the term stroboscope. Instrument which is used to make a cyclically moving object to be slow moving or stationary. The principle is based on Talbot's law and flicker-free perception of light. You can see this arrow. It is rotating at the speed of 60 rotations per second. Now suppose we view this arrow with a series of short flashes at 60 times per second. Now each flash will illuminate the object at the same position in its rotational cycle. So in the second image you can see that the arrow has started appearing to be stationary. Now if we do it at 61 flashes per second, the arrow is illuminated at a slightly earlier part of its rotational cycle. This gives a perception of the arrow rotating backwards, as you can see in the third image. To understand the same for vocal folds, we need to understand the body cover theory concept. The cover is the pliable and the elastic part which moves over the body. Cover, being pliable, is formed of the epithelium and the superficial lamina propria. Now what is glottic cycle? When the vocal folds are adducted, the subglottic air pressure gets built up and reaches a threshold which opens the vocal folds. It starts opening at the lower lip and progresses to the upper lip. As the airflow happens with Bernoulli's principle, the vocal folds start to close again. Again, this happens first at the lower lip and then the upper lip. This is the glottic cycle. In slow motion, this is how it looks like. You can see first the lower lip followed by the upper lip. Now, vocal cord is the busiest muscle of our body, and it is impossible to visualize it with the naked eye. So we have two types of imagery for that, stroboscopy and high speed. What is the difference? Stroboscopy gives us an apparent slow motion, and it is a superimposition of multiple glottic cycles into a single image. Whereas high speed imaging is the true slow motion with only one single glottic cycle being visualized. The stroboscope equipment does not emit a continuous light. However, if we start giving a constant frequency, then only we'll see the vocal cord as a static image. Hence, the stroboscope gives a difference of 2 to 3 Hz in the flashes, which illuminates different phases of successive voice cycles, giving it an appearance of an apparent slow motion. As I have already said, stroboscopy is the gold standard for dysphonia, but it is specifically indicated when the hoarseness symptoms are out of proportion to the laryngoscopic examination. It also helps us to assess the depth of the lesion. We can also prognosticate the patient and tell the future chances of the complete voice recovery. Also, in our practice, we have seen that stroboscopy post a conventional laryngoscopy has resulted in an altered and improved diagnosis in almost 30 to 40% of patients. This is how we perform nasal flexible stroboscopy. We can see there is a mic. The microphone picks up the frequency of the examinee's sustained voice, which triggers the stroboscopic light source. The camera is synchronous with the strobe light, so that whenever the light flashes, camera captures the image and we can get the stroboscopic video. How to perform the same in a patient? Can I have volume, please? First, the patient is told to phonate at their normal modal phonation to study the steady state vibration, followed by high pitch to see the vocal cords under tension. This is followed by a lowering of the pitch to understand the vocal mass effect over the vocal folds. And finally, we tell the patient to phonate loudly, which helps to test the relative stiffness of the vocal folds. A mild stiffness will be overcome by loudness. However, a very stiff cord, there will be no impact on increasing the loudness of phonation. We first record the fundamental frequency of the patient. As you can see, the stroboscope console showing the frequency of 166 Hz. It should be appropriate for the age and gender of the patient. If the frequency is higher than normal in males, we see this in pubophonia, whereas lower than normal in females is seen in androphonia. Now, it is very important to understand how to document and read the stroboscope. Various perception rating scales have been devised, the first given by Pogodka in 1999, which was called the stroboscopy evaluation rating form. This has been further improvised and improved in the form of a voice vibratory assessment with laryngeal imaging called as VALI. There are various parameters that we need to understand and document the same properly. The first one being the free vocal fold edge. This is studied when the cords are at full abduction, being normal in this case. They can be convex in cases of Rinke's edema. They can be concave in cases of presbyophonia or a deep sulcus, or they can be irregular in cases of vocal fold polyps or cysts. Again, amplitude. It is the degree to which each vocal fold moves laterally. Here you can see how to document it pictorially. In a model phonation, approximately 1/2 to 2/3 of the width of the mid-membranous cord gets lateralized, which increases on increasing the loudness. This is the normal amplitude. The amplitude decreases in cases of reduced tissue pliability, like you can see in this case of a sulcus, and also if there is a vocal fold mass lesion, where you can see the left cord having a reduced amplitude as compared to the right vocal fold. Now, this is the most talked about phenomenon, the mucosal wave. Whenever the vocal folds oscillate, the superficial tissue, that is the cover, gets displaced in a wave-like motion. A mucosal wave can be well visualized going from